Hi everyone, thank you very much for the opportunity to present in this masterclass in pathology. I'd particularly like to thank Professor Raj Singh and the organising committee for the kind invitation. I have no relevant conflicts of interest to declare. I know I'm put down to talk in the gastrointestinal pathology session, but I'll be talking about a more broad topic of what we call succinate dehydrogenase deficient neoplasia. As background, we'll start talking about its role in endocrine pathology, and hopefully that will enable us to understand the sort of mysterious entity of SDH deficient gastrointestinal stromal tumor, or GIST. Now, pheochromocytoma and paraganglioma are historically separated. By convention, tumors arising in the adrenal gland have been termed pheochromocytoma, and morphologically identical tumors arising elsewhere have been termed paraganglioma. For those who do a lot of pathology in this area, we consider pheochromocytoma and paraganglioma one entity. Now, they're rare, with a reported incidence of 3 per million. I do a lot of centralized testing for molecular pathology for pheochromocytomas and paragangliomas in Australia, which has a population of about 25 million, and I see more than 100 in a year, so that's clearly an underestimation. Now, historically, pheochromocytoma and paraganglioma were considered the tumor of tens, in that 10% were hereditary, 10% were malignant, and 10% were extraadrenal. However, we know that that is not true. It's now recognized that at least 30 to 40% are familial. Philosophically, they're all considered malignant, although only 5 to 15% actually metastasize. That was a consensual change with the 4th edition WHO Blue Book, whereas previously we talked about benign pheochromocytomas and we renamed them malignant once they spread. Now we consider them all malignant, but still only about 10% metastasis, and 30% are extraadrenal. That recognizes the understanding that pheochromocytoma and paraganglioma are the same tumor. Most important in the context of this talk is the recognition that so many pheochromocytomas and paragangliomas are hereditary. And at last count, there are at least 20 different susceptibility genes that have been recognized. I won't list them all, but it's important to recognize that genetic testing should be offered for at least the most common genes in all patients with pheochromocytoma and paraganglioma. And it really becomes a matter of resources and pre-tested probability to determine how many genes should be tested in each individual patient. There are different ways of expressing the different genes that are important, but for the purpose of this talk, I'll be talking only about the succinate dehydrogenase genes, which are known as SDH A, B, C, D, and AF2. Now, these genes fit together to form the mitochondrial complex 2, also known as the SDH complex. All the genes are on the autosome, but the proteins are assembled at the inner mitochondrial membrane, where C and D form the anchoring component and A and B form the active or catalytic component. The mitochondrial complex 2, or succinate dehydrogenase complex, is a key enzyme that actually links the Krebs cycle and the electron transport chain. So it's absolutely crucial to respiration. Now, what's interesting is the development of a unique immunohistochemical marker, SDHB. And the trick, and the really important trick to know about, is that loss of immunohistochemical expression of SDHB occurs whenever there is double hit inactivation of any of the components, SDHA, SDHB, SDHC, or SDHD. So even if you have an SDHC mutation, biallelic SDHD mutations, you'll see loss of expression of SDHB. The other trick is that somatic-only mutations are very rare. They do occur, but they're really quite rare. So whenever you get biallelic inactivation of one of the SDH components, you almost always have a germline mutation of the same component. And you can do immunohistochemistry of SDHB as a biomarker of this. So if we look at this conceptually, here we see the SDHB complex. Let's say there's a biallelic mutation of SDHD, which we know almost only happens when there's a germline mutation of SDHD. SDHD disappears, the complex becomes unstable. SDHB then floats off into the cytoplasm where it dissolves away and we get loss of expression. So that's the really important point, that because germline mutations of the SDHB mutations, somatic only mutations, SDH mutations, are very rare in the absence of SDH germline mutations, and loss of expression of SDHB occurs whenever there's biallelic inactivation of within the SDH proteins. Therefore, we can use negative immunohistochemical staining of SDHB as a biomarker of germline mutation and epimutation, which I'll discuss briefly, of any of the components of the SDH, either SDHA, SDHB, SDHC, SDHD, or SDHAF2. Okay, so let's look at a pretty typical immunohistochemical stain for SDHB. One point to make when interpreting SDHB immunohistochemistry is that the stain is mitochondrial, which means that positive staining is granular and cytoplasmic. And we'll talk later about why that's important. Here is a tumor that shows loss of expression for SDHB. It's a pretty typical paraganglioma. We can see up here, it's got a nested ball-like architecture. You can see that there's an internal positive control, which is granular and cytoplasmic and expressed in all the non-neoplastic endothelial and sustentacular cells. It's really important to see this internal positive control and ensure that it's granular and cytoplasmic before you consider a tumor to be negative for SDHB. So this is an SDHB negative paraganglioma. Here we have another case where there is a slight non-specific cytoplasmic blush in the neoplastic cells, but it contrasts very markedly with the distinctly granular and strong mitochondrial type pattern staining in the internal positive controls. So we can confidently call this SDHB negative or an SDH deficient paraganglioma. Here's a variety of cases that show the normal granular positive staining for SDHB, which means SDHB positive and not SDH deficient. Now, there are some warnings to interpreting SDHB immunohistochemistry, particularly in tumors associated with SDHD mutation. Here we see a paraganglioma arising in a patient with SDHB mutation. Now, the tumor cells themselves show quite a lot of SDHB expression, although it lacks the distinctly granular pattern of staining seen in the non-neoplastic cells. So the main trick in interpreting this is to compare the internal controls that are very dark and granular and mitochondrial to the non-specific blush in the neoplastic cells. So I could comfortably call this tumor SDHB IHC negative. Here we see another case where there's granular staining in the internal positive controls that contrast with the non-specific cytoplasmic blush in the neoplastic cell. So this tumor is considered SDHB negative or an SDH deficient tumor there at higher power. Now, some paragangliomas and pheochromocytomas associated with von Hippel-Lindau syndrome may show false negative expression of SDHB. So here we have a typical von Hippel-Lindau pheochromocytoma, very distinct and obvious granular positive cytoplasmic staining. But here's another case of a pheochromocytoma arising setting of von Hippel-Lindau syndrome. Now, the individual neoplastic cells show pretty much the same degree of expression that we saw in the previous cases associated with SDHD mutation, but the big difference is that there's essentially no expression or no difference in expression in the internal positive controls. So we don't see that distinct granular staining or a contrast between the internal controls and the neoplastic cells. So we would call this either SDHB positive or equivocal uncertain. Here we see the same at high power. So that's an important point to make, that maybe SDHB immunohistochemistry should only be interpreted by those who see a bit of it. Another clue, another important feature most important in assessing renal carcinomas is that conventional clear cell renal carcinoma that often has very strikingly clear cytoplasm often shows decreased expression because there's very few organelles or mitochondria in the cytoplasm. So as a result, there's very little SDHB expression. Probably the other important thing to remember about SDH deficient neoplasia is that tumors that are associated with SDHA germline mutation and subsequent biallelic mutation in SDHA in the tumor also show loss of expression for SDHA. So these tumors that are SDHA related are negative for both SDHB and SDHA by immunohistochemistry. In contrast, tumors associated with SDHC, SDHD, SDHB, or SDHAF2 mutation will show negative staining for SDHB, but positive expression for SDHA. So here's an example of a paraganglioma associated with SDHA mutation, and you can see the neoplastic cells are completely negative for SDHA, which contrasts dramatically with the internal positive controls, which are positive for SDHA in a distinctly granular and mitochondrial pattern of staining. Now, there are a few important things to remember about SDHA mutation. SDHA pathogenic mutations are not uncommon in the general population. In fact, they've been estimated to occur in up to 0.3% of normal, otherwise well people. So although SDHA mutation dramatically increases the risk of GIST and pheochromocytoma above background risk, it still has a very low lifetime penetrance. In fact, we've recently estimated that the lifetime penetrance of SDHA mutation is only 1.7%. So very commonly, one might find an incidental germline SDHA mutation, particularly when you're screening patients with a massive parallel sequencing approach with a very large panel. If you find an SDHA mutation in this setting, it may not in any way be related to the tumor the patient is being assessed for. So whenever you see an SDHA mutation in a massive panel, just bear in mind it may be an incidental finding. It still may be definitely pathogenic, but it's got a very low risk of penetrance. So in summary of paraganglioma and pheochromocytoma, if a pheochromocytoma or paraganglioma shows loss of expression for SDHB, we can consider the tumor to be SDH deficient. An SDH deficient tumor is prima facie, at first glance, evidence of germline SDH mutation. It's a little bit more complex than that because you can very, very rarely get somatic-only biallelic mutations, and you can have epimutations, which is somatic-only syndromic, but not germline hypermethylation of the SDHC promoter locus, but it's relatively rare. The other important thing to remember is that SDHA-related tumors are also negative for SDHA by immunohistochemistry, as well as being SDHB negative, whereas mutations of SDHB, C, and D are not associated with loss of expression of SDHA. And finally, when you identify an SDHA mutation in the germline, particularly when you're screening with large panels, just bear in mind they're not uncommon in the general population. So when you see one, the significance in the clinical setting. Now, I've highlighted some difficulties of interpreting immunohistochemistry for SDHB, as well as the background, and I'll just talk through some subtle clues to help you interpreting. The first point to make is that particularly with paragangliomas, SDH deficiency is more common in some locations than others. This can be expressed graphically in a whole lot of different ways, but certainly SDH mutation is relatively rare, maybe 3 or 4% of true adrenal pheochromocytomas, but particularly common in extra-adrenal intra-abdominal tumors, where it may be 30, 40%, or in tumors of the head and neck. So if you're assessing a paraganglioma outside the adrenal, the pretest probability is higher that it will have an SDH mutation, as it is if you're assessing a paraganglioma or pheochromocytoma in childhood. The second issue is that SDH deficient tumors can show subtly distinctive morphologic features. This is a classic SDH deficient paraganglioma, and you see it's got a very well-defined nested architecture, different to a non-SDH related case down here. At high power, very well-defined architecture with suggestion of a bit of cytoplasmic vacuolation or clearing sometimes. Here you can have more marked cytoplasmic vacuolation and clearing, but still this very well-deformed nested architecture. Now I'll emphasize that this phenotype genotype correlation is not 100%. It's just a clue that helps you interpret difficult to assess immunohistochemistry. Here's an SDH intact pheochromocytoma, and you'll see in contrast it's got a more sheet-like pattern with a very markedly and easily discernible granularity to the cytoplasm. Here we have another one that's SDH intact and has quite a lot of spindling. Similarly, it's very rare for an SDH deficiency to be associated with composite pheochromosomas or composite ganglioneuromas. So when you see a composite tumor, it makes SDH deficiency much less common. And finally, there are other phenotype-genotype correlations of SDH deficient tumors. We've mentioned the location. The SDHB is particularly associated with intra-abdominal extra-adrenal tumors, whereas SDHC and SDHD mutations are much more commonly associated with head and neck or mediastinal tumors. The other thing that I want to talk about briefly is the correlation between different tumors, not just pheochromocytoma and paraganglioma and SDH deficiency. All these germline mutations and non-germline epimutations associated with post-zygotic hypermethylation of the SDHC promoter locus are syndromic. So they're not just associated with pheochromocytoma and paraganglioma, but they're also associated with SDH deficient GIST, SDH deficient renal carcinoma, pulmonary chondroma, and SDH deficient pituitary adenomas. The manifestations of the different tumors are different for the different individual components, and that can be expressed different ways. This is probably the easiest way of expressing it, saying that SDHA mutation is particularly associated with SDH deficient GIST, SDHB mutation, particularly with renal carcinoma and pheochromocytoma, SDHC promoter hypermethylation or SDH epimutation, particularly with pulmonary chondroma. Now, they all overlap somewhat, but these are useful clues. Let's talk about SDH deficient gastrointestinal stromal tumor or GIST. And probably the most important clue to identifying these is that, with the exception of a single case report, all reported SDH deficient GIST reported to date have arisen in the stomach. So one should never say never in pathology, particularly academic pathology, but if a GIST is arising outside the stomach, it's not an SDH deficient GIST, or hardly ever an SDH deficient GIST. If it's multifocal outside the stomach, that's more likely associated with neurofibromatosis. Now, SDH deficient GIST account for 5 to 7.5% of apparently sporadic gastric GIST in an unselected adult population. So they're out there, but relatively rare. However, they account for the overwhelming majority of gastric GIST in the pediatric population. They show distinctive morphologic and clinical features that can be used to triage immunohistochemistry or identify those at higher risk, but they can only really be identified by immunohistochemistry or molecular means. So let's look at a typical SDH deficient GIST. Here you see a macroscopic specimen of a stomach, and one clue to the diagnosis of SDH deficient GIST is that they're commonly multifocal. So virtually without looking at the morphology, when I see a GIST with all these stomach section with all these multiple different tumors in the stomach, I have a high pretest probability that this will be an SDH deficient GIST. Now here we see the morphologic clues to SDH deficiency at low power. You can see there's gastric mucosa up here, so it's arising in the stomach. There is a multilobulated growth pattern at low power. Non-SDH deficient GIST push the smooth muscle away from the tumor. However, in SDH deficient GIST, you see these multiple septations of smooth muscle that divide the tumor up into multiple little components. It's a really important clue to the diagnosis of SDH deficiency. You can see this at high power again. These nests of cells separated by smooth muscle is a very typical feature of an SDH deficient GIST. Now, as I said, SDH deficient GIST can only be identified with certainty by molecular means of immunohistochemistry of SHB. And just as we discussed with paraganglioma and pheochromocytoma, it's really important to see internal positive controls as a marker in SDH deficient GIST. So here we see the internal positive control in the non-neoplastic epithelium, but also in the smooth muscle bundles separating the lobules of GIST. Now, SDH deficient GIST are quite different clinically as well as morphologically to usual SDH deficient GIST. And again, this can be expressed in many different ways. Almost by definition, SDH deficient GIST are not associated with somatic KIT or PGFR mutations. So one way of screening them is to go back and look at all your gastric GISTs that you've tested for KIT and PGFRA mutations and they're wild type. Go back and do immunohistochemistry, and a lot of those will be SDH deficient GIST. Now, although SDH deficient GIST are not associated with KIT and PGFR mutations, they basically always show diffuse, strong expression of both KIT and DOG1 by immunohistochemistry. And that's a really important clue because a lot of gastric GISTs are PGFR mutated, and a lot of PGFR mutated GISTs show an epithelioid morphology, which is a clue to SDH deficient GISTs that are often commonly epithelioid. However, most SDH deficient GISTs show only focal expression of KIT or a negative for KIT by immunohistochemistry, despite being diffusely strongly positive for DOG1. So when I see a gastric GIST as epithelioid, I think, oh, this could be an SDH deficient GIST. If it's positive for DOG1 but negative for KIT, I think it's much more likely to be a PDGFRA mutant GIST. Now, that doesn't obviate the need to do immunohistochemistry of SHB or molecular testing, but it's certainly a clue. Now, how do SDH deficient GIST differ clinically from usual GIST? Firstly, the classic Meitner algorithm, which is used to predict the outcome of SDH deficient GIST, basing the risk of metastasis being based on the mitotic count and size, cannot be applied in SDH deficient GIST. That is, small mitotically inactive GIST may still metastasize, and large GIST with a high mitotic rate may have a risk of metastasis not predicted by the algorithm. Another clue that SDH deficient GIST commonly metastasize to lymph nodes, and lymph node metastases are extremely rare in the setting of GIST that aren't associated with SDH deficiency. Whilst not all tumours not associated with SDH deficiency will respond to imatinib or other first and second generation tyrosine kinase inhibitors, it's pretty clear that SDH deficient GIST hardly ever respond to imatinib. Clinicians may think they respond because sometimes the metastases in SDH deficient GIST are extremely indolent and can be apparently stable for years or decades. So patients are on a TKI, stable disease, the physicians think that they've responded, but generally they don't respond to c-KIT inhibition. And as I said, the most important reason to make the diagnosis of SDH deficient GIST is the syndromic association. Approximately 30% of SDH deficient GIST will be associated with germline SDHA mutation, and those tumours will be negative for both SDHA and SDHB by immunohistochemistry. 20% will be associated with SDHB, C or D germline mutation, and about 50% will be associated with SDHC epi mutation, which refers to promoter hypermethylation of the SDHC gene. Now, these patients have syndromic disease, so they also may get pulmonary chondroma or paraganglioma, but they're not hereditary. And that relationship of pulmonary chondroma, paraganglioma, and SDH deficient GIST is termed the Carney triad. Here we see an example of a GIST associated with SDHA germline mutation. You can see the tumour is negative for both SDHB and SDHA by immunohistochemistry, whilst being diffusely strongly positive for KIT and DOG1. That's basically all SDH deficient GISTs are. I'll repeat the same warning that I gave earlier, that when you see a GIST and you see there's an SDHA mutation, particularly when it's identified on a large panel, bear in mind the possibility that this may be an incidental finding unrelated to the neoplasia. In that case, it's really useful to do immunohistochemistry for SDHA on the tumour. If it's SDHA negative, then it makes the germline variant more likely to be pathogenic in this case. But also remember, when you identify a patient with SDHA germline mutation, the whole risk-benefit equation in offering cascade genetic testing to family members is difficult because SDHA mutations are common in the population, up to 0.3% of the population, but yet have a very low penetrance, which we've estimated as being about 1.7%. Now, finally, I want to talk about SDH-deficient renal cell carcinoma. That's now recognized as a distinct subtype of renal carcinoma, and the majority have very distinctive morphologic features. The clinical clue is most importantly a syndromic association with GIST and paraganglioma, or onset at a young age, but they are very rare. In fact, we've estimated that about 0.05% of all renal carcinomas are SDH deficient. Macroscopically, other than the potential for multifocality, there's not many clues. Cystic change seems to be a feature that's not very common. The tumours are often relatively well circumscribed and show grossly or microscopically evident cystic change. These cysts often contain eosinophilic fluid reminiscent of thyroid colloid, and they often have entrapped non-neoplastic glands. By immunohistochemistry, we can see a nested architecture, which in some ways is reminiscent of paraganglioma. Sometimes there's microcystic change, but most importantly are the cytologic features, where the cells commonly show these distinctive cytoplasmic inclusions, which ultrastructurally are giant mitochondria. These cytoplasmic inclusions either contain eosinophilic fluid, similar to what we saw in the cysts, or flocculent, bubbly, pale material. Here we see that some of that flocculent, bubbly, pale material. But a word to the wise, these inclusions may be hard to find and maybe are only evident when you really search for them. So you should have a low threshold for doing immunohistochemistry SDHB in any difficult to classify renal carcinoma. Here you see these cells often have this flocculent eosinophilic cytoplasm that's not really oncocytic, doesn't have that very marked granularity of oncocytoma. When the tumours undergo differentiation, you may get prominent nucleoli, although in low-grade tumours, the nucleoli are normally inconspicuous, or they may develop a rigidity to the cytoplasm that makes them harder to register. And here we see a tumour with frankly sarcomatoid dedifferentiation, which would be morphologically indistinguishable from any other sarcomatoid tumour unless immunohistochemistry for SDHB is performed. Here we can see immunohistochemistry of SDHB highlighting we need to see an internal positive control in the non-neoplastic cells, both outside the tumour and the intract tubules. Now, to date, virtually all patients with SDH-deficient renal carcinoma that have had full genetic testing have been shown to be associated with germline mutation in SDHB. SDH, one of the SDH components of which SDHB is the most common, followed by SDHC and SDHA. So all patients with SDH-deficient renal carcinoma should be offered genetic testing. SDH deficiency does occur in pituitary adenomas, but it's extremely rare. And in our group, we've estimated that no more than 0.3% of all pituitary adenomas are SDH deficient. So whilst we recognise considering the possibility clinically, particularly for patients got a GIST paraganglioma or renal carcinoma and a pituitary adenoma, reflex screening immunohistochemistry of SDHB in pituitary adenomas is very low yield. So in summary, SDH deficient neoplasia refers to any tumour associated with loss of expression of SDHB. If you see SDH deficiency in any tumour, remember it really only happens in GIST, pituitary adenomas being rare, renal carcinomas, pheochromocytomas, and paragangliomas. There's very high likelihood of a germline mutation or systemic epimutation of one of the SDHC genes. I emphasize that you need to be careful when interpreting immunohistochemistry for SDHB. Most importantly, to see an internal control which contrasts to the pattern of staining. And we've emphasized the difficulty sometimes in interpreting the clinical significance of SDHA mutations because they do occur in the background population at relatively low frequency. Now with that, I'm going to take the opportunity to go through the shared slides. I've shared slides from 3 different SDH deficient GIST where I provided immunochemistry for both SDHB and SDHA, as well as c-KIT and DOG1 immunochemistry. And I've also shared slides from 4 different cases of SDH deficient renal carcinoma, where I've just provided immunochemistry for SDHB. So let's look at the first case of an SDH deficient gastrointestinal stromal tumour. Just as it loads up, I'll emphasize that at low power, the tumor often is distinctly multilobular. You can see this multilobulation being evident at low power with these bands of smooth muscle going through different areas of tumor. As we go to high power, SDH deficient GIST are commonly epithelioid, although it's a mistake to say that they're always epithelioid. They do often have a nested architecture that's somewhat reminiscent of a pheochromocytoma. And you see this epithelioid predominant morphology of relatively bland cells. Remember, one of the key differential diagnoses morphologically of an SDH deficient GIST is a PGFR mutant GIST. Those tumors, PGFR mutant tumors, often have myxoid change or multinucleation, whereas myxoid change is pretty unusual in SDH deficient GIST. So as we've said, this is immunochemistry for c-KIT. You'll see it shows diffuse, strong, positive expression in all neoplastic cells, and that's very typical for a SDH deficient GIST. And I see when you, as I mentioned before, when you see loss of expression or only focal expression, it's unlikely to be an SDH deficient GIST. See throughout the cells there. We'll move on to DOG1, which also will show diffuse strong expression of DOG1 in all the neoplastic cells. And then we'll move on to immunochemistry for SDHB. As I said, SDHB immunochemistry can be quite difficult to interpret, and I'll just take some time to walk through this at high power. Firstly, we see the internal positive control for SDHB in the non-neoplastic cells. Here we see the parietal and chief cells of the gastric fundus show distinct, strong, granular cytoplasmic expression. Now let's look at the SDHB immunochemistry in the neoplastic cells of the GIST. We can see, as we'll just take a bit of a while to buffer here, that the non-neoplastic smooth muscle cells and endothelial cells within the GIST show strong granular cytoplasmic expression, and we need to see that before a tumor is considered SDH deficient. However, the neoplastic cells themselves show loss of expression for SDHB. So we'll just walk along different areas of the tumor here, just confirming we have those good internal positive controls that are both granular and cytoplasmic. Now, this particular case was not associated with SDHA mutation, and so I'll show the SDHA immunochemistry in this case, which you would expect to be positive. And let's load it up, and you can see this is immunochemistry for SDHA. We'll just take a while to buffer as we go up to high power, and you can see that there's diffuse, strong, granular cytoplasmic expression of SDHA throughout the tumor. So this is an SDH deficient GIST not associated with SDHA mutation. This particular patient had the Carney triad, which is SDHC epi mutation. So we know it's not SDHA mutated. Let's look at the second case of an SDH deficient GIST that I shared morphologically. We'll see at low power, just as it comes up here, it's got this quite marked multilobulation. It's almost plexiform, and we have no way of knowing. These may be individual separate SDH deficient GIST. So it's quite marked multilobulation. We'll go into high power, and we can see this multilobulation with a very strikingly epithelioid growth pattern. Now, when you see these in core biopsies, certainly GIST isn't the first thing one thinks about because they're very epithelioid. You may even think about paraganglioma or pheochromocytoma or a neuroendocrine tumor. So quite marked multilobulation, some clonal definition. As I mentioned, SDH deficient GIST are normally epithelioid predominant, but they're not exclusively epithelioid. And here we can see some nodules with spindling architecture. I won't share the slides for KIT and DOG1, but you can see even without looking at the whole screen slides on the menu that these tumours are diffusely strongly positive for KIT and DOG1. Let's look at the SDHB immunohistochemistry up close in this case. And we can see that the SDHB immunohistochemistry shows loss of expression in the neoplastic cells. But let's zoom in and see how we need to contrast the distinctly granular staining seen in the internal positive controls. That's both the lymphocytes and endothelial cells within the tumor, as well as the non-neoplastic cells immediately adjacent to the tumor. And note that it contrasts quite markedly to the negative staining or weak cytoplasmic blush in the tumor. So I just emphasize again, tumor is negative for SDHB, because although we see a weak cytoplasmic blush, this contrasts to the diffuse strong expression seen in the internal causative controls. Let's look at the SDHA in this case and see whether the tumor is related with SDHA mutation. You can see this tumor is diffusely strongly positive for SDHA by immunohistochemistry, and the tumor shows a granular cytoplasmic expression of SDHA by immunohistochemistry. So this is a tumor that's positive for SDHA, so we know it's not associated with SDHA mutation. Finally, I'll look at our last SDH deficient GIST. We'll look at the whole section here, just while it loads up, and we'll see that this is another SDHA deficient case. Again, it's got that multilobulation that's a little bit less marked than seen in the other two cases. And again, we'll see, as we've seen in the previous cases, it's epithelioid, plump epithelioid to spindle cell predominant, these bands of smooth muscle making the tumor multilobulated. And we'll see at higher power, it's got this distinct lobulation and almost nested architecture. Let's look at immunohistochemistry in this case. I won't share the whole slides of KIT and DOG1, but they're there for you to look at in your own time, and you can see it's diffusely strongly positive for KIT and DOG1. Let's look at close the immunohistochemistry for SDHB. We'll see at low power there is a weak cytoplasmic blush. We observe the internal causative control in the epithelium is very obviously granular. We can see the internal positive control in the stromal cells is granular. But let's look at the staining in the neoplastic cells. We can see the endothelial and stromal cells within the tumor show granular cytoplasmic expression, although all the neoplastic cells show a weak blush. It contrasts quite markedly with that seen in the internal positive control. So this tumor is definitely SDHB negative by immunohistochemistry, or SDH deficient. Even though there's a weak cytoplasmic blush, it's such a contrast to the internal positive control seen in the endothelial cells and inflammatory cells scattered throughout the tumor. You can see that's very evident as we scroll through different panels of the tumor. Now let's look at SDHA immunohistochemistry in this case. Now SDHA can sometimes be difficult to interpret. Normally it shows quite strong staining, in fact stronger staining than SDHB cases. And here at low power we see this tumor, the SDHA shows weak expression, markedly less than seen in the epithelial cells. Now let's go into high power here, and we'll march around different areas of the tumor here, and you can see that SDHA in this case is quite difficult to interpret. We'll zoom into highest power. There are some areas where there is some expression of SDHA in the cells, but importantly, it's less marked than seen in the endothelial cells and stromal cells that serve as non-neoplastic controls. When I look at an area like this, I do detect some granularity to the cytoplasm, and I wouldn't be sure whether this tumor is SDHA deficient or not based on this area. So it's important to look all around. And as we look around, we see other areas where there's quite marked and definitely granular expression of SDHA in all the internal positive controls, and only quite weak expression in the neoplastic cells, which have a bit of granularity to them, but they're not very granular. So we keep on looking and we see other areas where there's much less marked expression of SDHA in the neoplastic cells that contrast with the internal positive controls. Let's zoom into an area like this. And you see that the neoplastic cells show only weak expression. Here's another area here. So there's expression, but it lacks that granularity. So if we zoom in here, SDHA is distinctly granular in this area, which contrasts with the expression in non-neoplastic cells. So I'll be the first to admit that this case is hard to interpret, and I'll encourage people to zoom through different areas of this slide in their own time. But I would interpret this as an SDHA negative case by immunohistochemistry in a GIST, and therefore this is an SDHA negative, SDHB negative GIST, which is therefore highly likely to be associated with germline SDHA mutation. But I fully accept that sometimes SDHA immunohistochemistry can be difficult to interpret, and often you need to look at several different areas of an SDHA deficient GIST before you're confident it's truly negative. You can see here in this area, the internal controls are very granular and mitochondrial, quite different to the other areas. Okay, let's go look at some typical SDH deficient renal cell carcinoma. So the first case I'm sharing now is case 4. It's what I'd call a classical SDH deficient renal cell carcinoma by morphology. This case doesn't have much microcystic change, maybe a little bit up there, but let's zoom in to high power to see the cytology. You'll see it's really easy. We can search around virtually anywhere here, and we'll see some areas where the cells have cytoplasmic inclusions or bubbly quality cytoplasm. Often the cytoplasmic inclusions are filled with clear material, but as we'll search around, we'll see other areas that have some more eosinophilic material, and it's really not hard to find classic intracytoplasmic inclusions. Now, one of the clues to an SDH deficient renal cell carcinoma is that although they have eosinophilic cytoplasm, they're not commonly markedly granular like you see in a classic oncocytoma. So it's this eosinophilic but not really oncocytic cytoplasm. Much like SDH deficient GISTs and paragangliomas, there's often a nested quality to the architecture, and they have a readily dispersed chromatin in many low-grade cases. But really the best clue is these intracytoplasmic inclusions or pseudo-inclusions containing eosinophilic or clear material. And once you get your eye in for them in this case, they're very widespread. Let's look at immunohistochemistry for SDHB in this case, which I'll just load up here as I get the slide up, just to practice interpreting immunohistochemistry for SDHB. It's relatively easy to interpret in these renal tumours. This is SDHB immunohistochemistry. We can see a good internal positive control in the non-neoplastic tubules, which is distinctly granular at the edge of the tumour. And going through the tumour, we can see all the neoplastic cells are completely negative, with the non-neoplastic cells here, the tubule at the edge, demonstrating distinctly granular staining. So that's the typical SDH deficient renal cell carcinoma. We'll load up our next case here, which is case 5. This is another SDH deficient renal cell carcinoma. We'll just zoom in. It's a relatively small sample and quite a big size. And if we go into high power here, we'll see the tumours again show a bubbly quality of the cytoplasm in some areas, but yet have quite bland nuclear features. In this case, the classic cytoplasmic inclusions filled with eosinophilic material are readily hard to discern, but many of them have the type of inclusions containing clear material or flocculent material. Let's look at immunohistochemistry for SDHB in this case and see if this one is easy to interpret. We'll just zoom in here as it loads up and we'll go to higher power. And firstly, we like to see internal positive controls in the non-neoplastic cells. Have we got some? Let's look around. We're not seeing great internal controls. Maybe there'll be some better ones at the edge. Here we see some internal controls in the endothelial cells. Here's a good endothelial cell with internal positive controls. Let's just look around. Maybe we'll get a better internal control where there's an edge effect. It's just taking a while to buffer, but there are some internal positive controls in the non-neoplastic areas. Here we go again, back to that area we saw before. Just let it buffer up to high power, and the neoplastic cells are completely negative. Okay, let's look at case 6 here. Another SDH deficient renal cell carcinoma. This tumor shows quite marked microcystic change, and those microcystic areas contain that distinct pale, very sort of thin eosinophilic fluid that looks like thin colloid you might see in the thyroid, very pale material. Let's go to higher power, and we can see quite obvious bubbly quality of the cytoplasm. This is quite a classical morphology for an SDH deficient renal cell carcinoma. Here we see these classic intracytoplasmic inclusions that contain clear material and actually represent giant mitochondria. In fact, in this case, the intracytoplasmic inclusions are very widespread throughout. This is a low-grade SDH deficient renal carcinoma with typical bland nuclei, sort of fairly difficult to discern nucleoli, but G in this case has very easily identifiable classic intracytoplasmic inclusions. Let's look at immunohistochemistry for SDHB in this case, see if it's easy to interpret. Remember, sometimes you need to repeat immunohistochemistry of SDHB to get a good internal positive control. Let's zoom in at low power. It looks pretty negative, but as you always like to see good internal positive controls before we see a case negative. So let's zoom around looking for some internal positive controls. Here we have all the tumor cells are negative, but really I want to see a good internal positive control. Here we have some inflammatory cells, which serve as the internal positive control. Here we have some endothelial cells, which serve as the internal positive control. But I really want to see some really good internal positive controls, even in a tumor like that shows no expression as well in any areas, just to ensure that we've got a working stain that's interpretable. Here we go to higher power. There, some endothelial cells with a good granular internal positive control that contrasts with the weak cytoplasmic blush that we see in some of the neoplastic cells. Let's look over to the edge here. Way over here at this edge, let's see if we get better controls. Here we see again a few strong granular cytoplasmic stainings in the endothelial cells, inflammatory cells, contrasting with the negative or only weak cytoplasmic blush in the endothelial cells. Finally, let's look at our last case to share for this session. It's an SDH deficient renal cell carcinoma. Here we see the non-neoplastic kidney. And let's look at this case. This is a variant morphology. It doesn't show that classic morphology we've seen in most of the other cases. Here we do have just really an undifferentiated renal carcinoma. Here it's got a papillary or pseudopapillary architecture and quite sarcomatoid change really. If you really search, you might be able to, perhaps with the eye of faith, discern some intracytoplasmic inclusions, but I defy anyone to identify an intracytoplasmic inclusion with confidence in this case, at least not prospectively until you see the immunohistochemistry SDHB. Maybe that's one there, maybe it's there, but really I would call this morphologically an unclassifiable renal cell carcinoma. But let's look at the immunohistochemistry for SDHB in this case. Here we see the SDHB immunohistochemistry just as it loads up, and we can see that there's quite easy to interpret internal positive control in the non-neoplastic tubules. You can see a very granular and distinct expression, but the tumor itself shows completely absent expression of SDHB immunohistochemistry in the presence of a definite internal positive control. So we can see it's just taking a while to buffer here, a distinct granular internal positive control along the endothelial cells, inflammatory cells, endothelial cells within the main tumor mass. And that contrasts with the completely absent nucleus, cytoplasmic staining in the neoplastic cells. So that's the case that would be morphologically unrecognizable as activation deficient renal cell carcinoma, but because we have a low threshold performing immunohistochemistry SDHB in any difficult to identify renal cell carcinoma, we've identified it. So in summary, my name is Anthony Gill. I'm a pathologist in Sydney, Australia at the University of Sydney and Royal North Shore Hospital. Feel free to follow me on Twitter. If you have any questions, feel free to shoot me a question on Twitter. You can either DM me or you can just post it on my Twitter page, or you can email me. All my contact information is available on Twitter. I thank you very much for the opportunity to talk, and thank you again to the organisers for the kind invitation. I won't be online for any live questions because the time difference is too much, so I'll just end the session there. Thank you very much.